to apologize that I have informed, I have made a confusion previously. So today, Professor Hyung Im, not me, will deliver the lecture regarding the breast cancer correlative imaging. So yeah, we will start 1 minute later. Thank you very much.
All right, it's now time's on. So hello everyone, welcome back to the lecture series. Actually the confusion was made by me, so I apologize to you all and Professor Saw as well. So today I'm going to talk about the correlative imaging in breast cancer. So the content will include, as usual, AJCC staging in 8th edition and some FDG PETICT case reviews. And HER2 PET imaging is included in this today's talk because it's one of the emerging molecular imaging area in breast cancer. And I found that in breast cancer, there is not a lot to say about correlative imaging. So I included that part today. So hope you enjoy it. So this is an overview of 8th edition of AJCC staging in breast cancer. And the unique thing in breast cancer staging in 8th edition, they included the anatomic stage and also prognostic stage. So anatomic stage is regular TNM staging, and prognostic stage included the tumor grade and hormone receptor and HER2 expression status, and also multi-gene panel testing. So I'm going to talk about in detail in the latter part of today's talk. And for some teaser for multi-gene panel testing, there is one very nice multi-gene panel testing, which is named Oncotype DX recurrence score. And this is used for specific situation that patient with T1 and T2 hormone receptor positive, but HER2 negative and lymph node negative tumor. If the score is less than 11, then the score, the staging is downstage actually. I'm going to talk about this in the later part of today's talk. And the anatomic staging, regular anatomic staging includes clinical and pathologic, post-therapy and restaging. And we are all imaging guys, so we are focusing on clinical staging, which is based on finding from clinical examination, diagnostic imaging, and or core biopsy specimen. So this is anatomic T staging for breast cancer. And you can see the T0 means no evidence of primary tumor, and TIS divided into DCIS and Paget disease. And DCIS is ductal carcinoma in situ. And Paget disease is a clinical diagnosis that has an exudate or crust of the nipple or areola caused by infiltration of the epidermis by non-invasive breast cancer epithelial cells. So if Paget disease is not associated with invasive carcinoma or DCIS, then the stage, T stage will be T inside of Paget. And T1 is subdivided into 4 different categories. One is micro, T1 micro, which means T1's tumor size is less than 1 millimeter, and T1A between 1 and 5 millimeter, T1B between 5 and 10 millimeter, and C between 10 to 20 millimeter. So it's smaller size is divided into a very narrowly. So we um, cannot determine this T stage with the FDG PET scan. And T2 stage means T 20 millimeter to 50 millimeter, and T3 indicates 50 millimeter size over 50 millimeter size without any extension to a chest wall or skin. And T4 includes tumor with extension to chest wall or skin, divided into 4 different categories. And T4A indicates chest wall invasion, and T4B indicates macroscopic skin changes, including ulceration and or satellite skin nodules and or edema. And T4C includes both A and B, and T4D is inflammatory carcinoma. That's described in this figure like this. So T1 and T2 is not touching any skin or chest wall, but and T3 as well. But T4A involves the chest wall. And chest wall includes ribs and intercostal and serratus anterior, but not pectoral muscle. So pectoral muscle is not included in the chest wall, even though it's the breast cancer is involving pectoral muscle is not T4. And T4B indicates satellite nodule or skin involvement, macroscopic skin changes, and also this skin changes is included in T4B, and T4C includes both finding down to chest wall to up to skin involvement, and T4D is inflammatory carcinoma. It's also clinically characterized by diffuse erythema and edema involving approximately a third or more of the skin of the breast. And although it's not included in the T staging, multifocal and multicentric disease should be differentiated because of the different surgical method is applied. So if there is multiple primary tumor lesion, you can say it's either multifocal or multicentric. And multifocal means that those tumors occupies the equivalent or less of the 1 quadrant of the breast. So surgical method could be breast conserving surgery. And if it's a multicentric disease, it's those multiple tumors are involving more than 1 quadrant of the breast. So mastectomy should be done in most cases. And this is N staging now. N0 is no regional nodal metastasis. N1 indicates there's a metastasis to ipsilateral level 1 or 2 axillary nodes, and that is movable. And N2 means N2A differentiated into N2A and B. N2A indicates the same area of axillary ipsilateral level 1 and 2 nodes metastasis, but it's fixed and or matted. So it's different from N1. So it's hard to know that it's fixed or matted from the CT or FDG PET scan. So it's really a clinical decision to make. And N2B indicates internal mammary nodes metastasis, but there is no axillary metastasis. And N3, can move on to N3. N3 is divided into ABC, and if there are ipsilateral internal mammary and axillary node, then it goes to 3B. And 3A indicates the level 3 axillary node metastasis, and 3C includes ipsilateral supraclavicular node metastasis. So you can see in this figure clearly, so N1 movable ipsilateral level 1 or 2, N2A same area but fixed and matted, N2B goes to internal memory but no axillary node. If there's axillary node, then it's N3B. And N3A is level 3 axillary node, and N3C it's supraclavicular node. So FDG PET CT scan is good for detecting and diagnosing lymph node metastasis. So it's very important to differentiate this lymph node station in the imaging. And the lymph node station is described like this. So the level 1 to 3 is actually it's very easy, much easier than lymph node station from lung. The one particular structure is used for differentiating the level 1 to 3 lymph node station in the breast. So it is the pectoralis minor muscle. So the lateral border differentiate level 1 and 2 axillary lymph node, and then medial border differentiate level 2 and 3 lymph node station. And internal mammary node is also frequent site for metastasis. And internal mammary node is run alongside with the internal mammary vessels and sternum. And supraclavicular node is over in the supraclavicular fossa, and also there is intramammary. So it's different between internal and intra. And intramammary node means that the lymph node is inside of the breast, and it is considered as an axillary lymph node for staging. And this is the M staging. So M0 has one particular category of I plus. Actually, this means that tumor cells or deposit measuring less than 0.2 millimeter is detected in circulating blood or bone marrow or non-regional nodal tissue, then it can be considered as M0I plus. And M1 is very easy and not divided like in lung cancer. So it's just distant metastasis based on clinical or imaging findings. Right. So based on those TNM stratification, can say the anatomic staging like this. So 1, 2, 4. So this is regular anatomic staging. And there is one other part in breast cancer staging system, which is a prognostic staging, because the evidence is growing rapidly that the tumor biology is related to the treatment response and also prognosis of the patients. And especially in breast cancer, the targeted drugs like hormonal therapy and HER2 targeted drug are especially like very nice efficacy in those patients. So it is very important to divide those patients using these prognostic markers. So those markers are tumor grade and hormone receptor in HER2 in multigen panel, as I explained in the first page of today's talk. And one important thing is this guideline suggests to maintain the anatomic stage, which means each patient should be able to be assigned a purely anatomic stage because these prognostic staging is not appropriate or not available for all patients worldwide. So the anatomic stage is also still very powerful prognostic stratification method. So maintaining anatomic stage, but we can further utilize the prognostic stage for the accurate stratification and treatment application. So, so this is three most commonly used prognostic factor in the breast cancer. So tumor grade and ER and HER2 status. So this is one study which is included in the AJCC guideline to show those factors are has powerful influence on patient prognosis. So if you give points according to grade and ER and HER2 status as 0 or 1 and sum up that, and then even though the patients has the same stage according to TNM stage, if those risk profile is given to those patients, then the patients' survivals are significantly different according to the risk profile. So it's similar in early stage, but when you go to the advanced stage like 3A, although the number of patients is not too many, but if there is no risk profile, then 100% of the patient was survived for 5 years. But if the patient had 3 points, and the survival goes down to 68%, and 3C like 33%. So even though a patients have same TNM staging, their prognosis will vary widely according to these prognostic factors. That is why prognostic staging is adopted in this 8th edition. And how to stratify the patients. Actually, it's too long to review those all. So this is a part for the prognostic staging. So it goes pages long. So, but I'm showing this to you because you can have some sense how this prognostic staging is done. So if TNM staging is this, then tumor grade is considered first, and then HER2 status and ER status and PR status, and then final prognostic staging is given to those patients. So this list goes on, and one particular sector is using Oncotype DX score. So this score can be used in a particular subset of patient who has T1 or T2 and N1, M0 and HER2 negative and ER positive, then those patients are considered as stage 1A. If T2, N0, M0, then the anatomic stage will be stage 2A, like T2, N0, M0. But if if this condition and the Oncotype DX score is less than 11, then the patient have very good prognosis. So the stage is downstaged in this subset of patients. So how come this score was incorporated into these AJCC guideline? Because there are very strong evidence in the literature and prospective trials, and this is one of those, and it was published in 2015. This 21 gene expression assay is the commercial name is Oncotype DX, and they showed that enrolled the patients who have hormone receptor positive, HER2 negative, and N0, and tumor size less than 5 centimeter. So which means less than like T2 or T1 or T2, and N0 and M1, and HER2 negative and ER or PR positive. And then among 10,000 patients, about 1,600 patients had a recurrence score of less than 11 according to the Oncotype DX. And then they received the endocrine therapy alone without chemotherapy. According to the TNM staging, those T2 stage should receive the adjuvant chemotherapy previously, but chemotherapy is very cytotoxic. Chemotherapy has a lot of adverse events. So in this study, they look at see if there is chance that those patients have only endocrine therapy, not chemotherapy. And they found that those subset of patients had a very nice prognosis, even though they didn't receive the cytotoxic chemotherapy. So you can see the very nice survival graph of those patients. So all Kaplan-Meier survival curve shows over 95% of the patients were disease-free for 5 years, and 5-year survival rate was high as 98%. So this study is the basis of decision of this AJCC guideline. So if the patient less than 11, then goes to downstage, and the patient will not receive the cytotoxic chemotherapy after the surgery. And furthermore, in 2018, the same multi-panel gene assay was performed. This time, there is no limitation for tumor size. And again, same HER2 negative and axillary no negative, but hormone receptor positive patients were enrolled and compared, randomly assigned, and the patient who had higher than 11, so 11 to 25, it's a mid range of recurrence score, and those were randomly assigned to receive chemo plus endocrine therapy or endocrine therapy alone. And the result shows that there was no significant difference in the prognosis. So based on that finding, those patients can be treated with endocrine therapy alone. So cytotoxic chemotherapy is not recommended in this subset of patients. So the progress from the previous study is recurrence score is higher than 11, and there is no T staging tumor size restriction. So you can see the endocrine therapy and chemoendocrine therapy survival curve are just identical. So chemotherapy is a painful procedure, so it's really nice for those patients to have endocrine therapy alone. So based on that study, so this is NCCN guideline. You can see N0 and hormone receptor positive, HER2 negative disease, and this gene panel, the OncoDX, is suggested, and if the recurrence score is less than 26, so it's mid-range, then endocrine therapy is suggested. That was the anatomic and prognostic staging system in the 8th edition of AJCC guideline. And now I'm going to talk about the FDG PET scan in the staging system. So this is, again, the summary in the NCCN guideline. I look for all the PET scans in the guideline. And this is the summary of that. So so it's written in the NCCN guidelines. So that means that this recommendation has a highest evidence for the management of patients. So FDG PET scan is considered for initial staging of breast cancer, but it's the not all stage. In case of lung cancer, it was recommended for all staging, but in breast cancer, it is also only considered in the patient who are considering the preoperative systemic therapy. So that means it's advanced breast cancer. And also it is recommended in inflammatory breast cancer that was T4D, which is pretty high stage, and metastatic disease for sure. See if there is another metastasis or to evaluate the burden of the metastatic disease. And also it is recommended after initial surgery in pathologic analysis, if the patient had more than 4 positive axillary node metastasis, then FDG PET scan is recommended to see if there is occult distant metastasis. And in the recurrent disease, FDG PET is also recommended to evaluate the systematic metastasis. And also in the metastatic disease, FDG PET is used for treatment response monitoring. So otherwise, FDG PET was not recommended because there is not enough evidence to support. So this is a relatively recent review paper from JNM in 2016 to show FDG PET scan in baseline staging. So you can see the clinical value of FDG PET scans overview from this table. You can see in this study to detect metastasis, it has in this study, it has very good sensitivity and specificity. And in this study, sensitivity was slightly low, but the specificity was pretty high for detecting the axillary lymph node metastasis. And 7 patients were identified as having distant metastasis, which was not known by the conventional imaging. And in this study, importantly, the therapeutic management was changed in 8% by FDG PET scans. And in this case, clinical stage was changed in 30% of the patients using FDG PET scans. And all cases were upstaging, so FDG PET is finding like occult metastasis. So it was all upstaged. And in this study also, there were some patients who were upstaged according to FDG PET stage PET scan. And in this case, the therapeutic management was changed according to the FDG PET scan. But normally, in almost all cases, FDG PET is good for finding metastasis. So it is used for upstaging, and normally changing of the therapeutic management will be including adjuvant cytotoxic chemotherapy or more intense therapies are included according to the FDG PET CT scan. So this is very simple summary of the sensitivity and specificity of FDG PET CT scan. It was published recently in 2019. So there is no like numbers because the previous studies are quite heterogeneous in terms of patient population and staging and the situation, like if that's baseline or post-surgery or post chemotherapy or recurrent disease or metastatic disease. So those are varied widely. So there is no number to show, but very simple summary is here. So for primary tumor, the FDG PET CT scan is not very good to evaluate the primary tumor, but for evaluation of axillary lymph node, it has pretty high specificity, but relatively low sensitivity. But for the axillary lymph node metastasis or distant metastasis, the sensitivity and specificity is quite high. Similar in which is similar with lung cancer. And these are the summary of areas of greatest clinical effect of FDG PET CT scan. So essentially, these are similar with the recommendations in NCCN guidelines. One other thing is really not in case of breast cancer, but if you find incidentally detected FDG avid lesion in breast, then mammogram or ultrasonal sound is recommended, because in one retrospective study, there is a 30 to 40% of chance of malignancy in these lesions. And these three are similar with the NCCN guidelines. So systemic staging, if the breast cancer is locally advanced stage, and can use the FDG PET scan in treatment response evaluation, and also to confirm the recurrence and to determine the disease metastatic burden in recurrent disease. So, and then those were more confirmed if confirmed effect of the FDG PET scan, which is included in the NCCN guideline. But there are another value of FDG PET scan, which is prognostic value. So I have shown knew that FDG PET scan was very good at predicting clinical outcome in lung cancer, and also it is very not good in breast cancer as well. But the evidence, the literature evidence is not quite large compared to lung cancer, but still there are quite a papers out there to show the FDG PET-CT scan has a prognostic value in breast cancer. So this is one study I've done in more than 7 years ago. We included 24 patients with breast cancer, and they received 4 to 6 cycles of neoadjuvant chemotherapy before surgery. And the FDG PET-CT scans were done at baseline and after second cycle of chemotherapy, which is called interim scan. And SUV max and NTV and TLG were measured for evaluation. So in this case, baseline and interim scan were done. So the percent reduction rate of those parameters were used for the analysis. And the patients were divided into responders and non-responders based on the histologic evaluation in the surgical specimen after neoadjuvant chemotherapy. And as expected, the reduction rate, percent reduction rate of FDG PET parameters were higher in responder group, SUV max and MTV and TLG as well. And the difference between the two groups was significant in MTV and TLG, and SUV max showed a trend of difference. And those parameters were effectively predict the responders and non-responders with the area under curve of 0.886 and 0.743 for SUV max. So in this study, we couldn't evaluate the survival rate itself, but we compared with the responder and non-responder after neoadjuvant chemotherapy to show that FDG PET parameter was useful for predicting the treatment response. And the similar studies have done for 7 years. Multiple studies were performed for 7 years, and recently there was a meta-analysis to include all of those study results. And in this case, in these studies, used the FDG PET parameters at baseline and interim or post-therapy scan during the neoadjuvant chemotherapy, and then reduction rate or post-therapy SUV parameters were used to predict the survival itself, not the response of the neoadjuvant chemotherapy. So it's more valuable information. So this study included 21 studies consisting of 1,630 patients. And these are the studies included. As you can see, the PET timing was either after completion of neoadjuvant chemotherapy or in the middle of the neoadjuvant chemotherapy after 3 cycles or 2 cycles. And the parameters were used most frequently percent delta SUV max, which is percent change between baseline and post-therapy or interim therapy. And the cutoff was made like over 80% reduction is considered as PET response in this study, and that was evaluated if that PET response is associated with survival, disease-free survival or overall survival. And these studies are actually quite heterogeneous. So some study used percent SUV max reduction rate, some used complete metabolic response, or some used percent reduction in TLG or SUV peak. And the cutoff were all different. In some cases, 80% was cut off, or 72% was cut off, and 62% was cut off in this study. So quite different and quite heterogeneous. And some study looked at both disease-free and overall survival, and some looked at disease-free alone. So there was very big heterogeneity in these studies. Although if those study results are pulled in, so if to see if FDG PET response is related to disease-free survival, then interim PET scan showed a hazard ratio of 0.21, which means the PET response is related to good prognosis. And post-therapy also showed a bit similar hazard ratio to predict recurrence. And for overall survival, interim scan showed a very nice predictive value for overall survival, and post-therapy scan was the same, similar, shows similar hazard ratio. So that being said, these PET response during or after neoadjuvant chemotherapy was associated with patient survival. So we can say that with this meta-analysis, which has higher evidence than single study. And there is another study to show, so the previous studies are using baseline and interim or post-therapy scan to have the reduction rate to predict the prognosis. But in this case, those patients underwent FDG PET scan at baseline. So this study is looking at if baseline FDG PET-CT parameters are predictive of prognosis or not. So, and the patients were all triple negative breast cancer. And these are the typical prognostic factors, including TNM staging and Ki67, EGFR mutation, and CK5/6. So those known prognostic factors were predictive of disease-free survival. And in subgroup of those 200 patients, there were 79 patients who had FDG PET-CT scans, and those FDG PET-CT scan values were predictive of disease-free survival, even though it's only baseline scan. And even after adjustment of the known prognostic factors, the SUV max was still predictive of disease-free survival, which means it's independent prognostic factor over TNM staging. So this is one example to which was shown in this paper. And this patient had a small breast cancer with low SUV max, and this patient had large breast cancer with a pretty high SUV max. I think it would be nicer to have similar breast cancer size but different SUV max. I think that would be a more clear example to show that FDG PET parameters are useful for independent prognostic factor in breast cancer, but this is what they showed. So the Kaplan-Meier survival curve showed nice stratification according to the SUV max value. So higher SUV max value show worse prognosis, lower SUV max value shows good prognosis in these patients. And one other study from 2016 in AJR, they assessed the prognostic value in recurrent breast cancer. And in recurrent breast cancer, they measured all SUV max peak and MTV and TLG and see if those are predictive of overall survival. So these patients are already recurrent patients, so there is no disease-free survival. So just see if that is predictive of overall survival. And in univariate analysis, the SUV and peak TLG was predictive of prognosis, but in multivariate analysis, it was not independently prognostic. But in univariate analysis, those FDG PET parameters shows a very nice prognosis stratification. And you can see the worst prognosis in the patients with higher SUV max or peak or TLG or MTV. So for the prognostic value of FDG PET CT scan, so I think there is most powerful evidence is that from that meta-analysis. So FDG PET reduction, PET response during or after neoadjuvant chemotherapy, that is predictive of survival. And there is not many studies, but there is one study to show that baseline FDG PET CT scan is predictive of disease-free survival. And this study shows that FDG PET scan PET parameters at recurrent disease was predictive of overall survival. So there is not very much of literature out there yet, but I think FDG PET parameters could be a good prognostic factor, which could be included in prognostic staging in AJCC guideline. So, okay, we have one question here. This study has also included other prognosis for any of these studies. It's also included. Oh, you mean those? Oh, okay, right. So let's move on to some case reviews. I think anyone who is reading FDG PET, who have read some breast cancer FDG PET CT scans, like more than, let's say, 50 scans total, then these scans are not difficult to read because it's not very complicated, I think. But let's see some of these cases. So this patient is initial staging for FDG PET CT was done for initial staging. So you can see in the MIP image, large and bright left breast cancer is shown here, and some suspicious uptake is seen in this left axillary area. And otherwise, I don't see any suspicious lesions from the MIP. And let's see the transaxial image. And you can see the bright primary tumor here. And so it's attached to a chest wall, but it's not our responsibility to call any chest wall invasion or not. You can just check the whole breast to see if there is another focal lesion in the primary for the primary tumor, and there is nothing like that. And when you go up, you can see the enlarged lymph node in the axillary level 1 area. This is level 1 because you can see the pectoralis major muscle here and minor muscle behind. So it's in the lateral part from the lateral border of pectoralis minor muscle. So it's level 1 lymph node. And you can see the pectoralis minor muscle for the next cases. So you can see this pectoralis minor run through all the way up to like cricoid process, the scapula. And other than that, you don't see any suspicious uptake or enlarged lymph nodes here. So the interpretation will be left breast cancer with suspicious left axillary level 1 lymph node metastasis without distant metastasis. And this case shows similar finding. So you can see like multiple lesion actually in left breast and suspicious uptake in the left axillary area and some symmetric uptake in the supraclavicular area. So we should see that in transaxial images. You can see the primary tumor first. So the biggest one is in the subareola area and some other nodules in beneath here. And also far down there is one other lesion was found. And also there is level 1 lymph node, enlarged lymph node with high, increased FDG uptake, suspicious for lymph node metastasis, and see if there's another one. There's another one, but still level 1 because there is a pectoralis minor muscle and nothing else in the level 2 or level 3. And in the supraclavicular and lower neck area, there are symmetric FDG uptake, but this is very easy to differentiate with the pathologic finding because those uptake is within the fat tissue. So this is typical finding for brown fat uptake. And then we have to see the internal mammary area because internal mammary lymph node metastasis is changed the N staging. So you can see carefully in the parasternal area, goes down. And you can see a enlarged lymph node here. So it's not seen in the right side, but it's definitely enlarged lymph node with slightly increased FDG uptake. So interpretation will be there are some multifocal, multicentric left breast cancer with suspicious lymph node metastasis in axillary and internal mammary node. So this should be This should be confirmed by a biopsy to uh, to do the accurate staging. And then next case, you can see. So this is in one site, this patient has multiple pathologic lesions that might be scan. So this patient could have right breast cancer with multiple metastases in lung and potentially bones. And there is one unusual focal uptake in the uh, could be internal memory, could be mediastinal, could be hilar node. So you can see that in the transaxial imaging. So here's the primary lesion in the right breast. And interestingly, there is no whole lot axillary node metastasis uh, except this level 1 node. And let's look at the internal memory. I don't see any abnormal lymph node in the internal memory area as well. But there is one intense uptake in the right hilar lymph node area, which is unusual in breast cancer. And also there is a lot of multiple liver lesions, which looks like metastasis in the bone lesion in lumbar vertebra. So you can see the lung area as well. And then you can see some of the consolidative lesion in the lung field with mildly increased uptake of FDG. So it's not clear, but I think this lung lesion could be some inflammatory process. So this 10R lymph node could be inflammatory lymph node, which was caused by this inflammatory lung lesion, but it's not conclusive. But I think that right hilar node receives the lymph from the lung area, so it's not. It's very rare to have that area lymph node metastasis in breast cancer. So I guess that should be confirmed after follow-up using the follow-up scans. But in this PET scan, we concluded that there was right breast cancer with lymph node metastasis and liver bone metastasis, but the right lung and 10R lymph node could be a inflammatory process. This is another case with very clear uptake in the left breast and the multiple lymph nodes. So you can see that in transaxial imaging. So you can see very huge left breast cancer, and then axillary level 1, and this could be level 2 or 3, because here's a pectoralis minor muscle. I can say level 3, I guess, because it's not important because there is another lymph node metastasis in supraclavicular area. Then it's already N3 disease. And also there is a clear uptake in the left internal memory area with enlarged lymph node. So is suggestive of multiple lymph node metastasis in the multiple axillary and internal mammary area. And also otherwise, here is a small yet slightly increased FDG uptake in the prevascular area. So this could be metastasis as well. But it's not sure because it's not common area for those in the breast cancer. So those were the FDG PETICT scans for typical staging situation in advanced breast cancer. And I don't think it's too difficult to read. And this is one example of false positive in left axillary lymph node. Do you have any idea why this false positivity was occurred? It's like a quiz. It is very easy when you see the MIP image because if the extravasation of FDG will lead to the focal uptake in the axillary lymph node. So that is one interesting image from the previous paper. So that was it. That was it for the first part. And so I explained the AJCC staging system, both anatomic and prognostic, and explained the advantage, like confirmed utility of FDG PETICT scan in breast cancer imaging. And then one other potential area of using FDG PETICT scan in breast cancer is to use for prognostic evaluation, since breast cancer is adopting a prognostic stage. So I think there's a good chance for FDG PET scan to be included in the system as well. And also I explained these some other cases from our hospital. So is there any question for this first part? If you have any question, then leave your question in the chat, and let's have a 10-minute break, and I'll talk about the HER2 imaging. All right, thank you. I'll start in 10:12. We'll see you later. All right. Okay, there's one question in the case review. I think second to last case. And this one. I'm not sure if this is the right case, but internal memory. not sure which was it. Maybe this one. Yeah, I don't. Yeah, I think it's it's maybe we can. It would be more clear to with the CT scan, but according to this transaction imaging, I'm not sure if it's enlarged lymph node or not. So yeah, so I think it is necessary to firstly to see if there is enlarged lymph node or not, and then check the SUV uptake of that. But there is no actually clear cut for the to determine pathologic or normal lymph node or not. So I think it is for this case. In this case, I don't think it's an enlarged lymph node. But if there is enlarged node and the uptake is kind of equivocal, then I think it would be nice to report that because they can do the biopsy for the for the accurate staging. So that's my opinion.
Can I ask another question?
Yes, sure.
Yeah. About SUV, do you use SUV max or SUV peak? And what value have you do you consider like cancer or something like that?
We in our hospital we use SUV max because yeah, we just report the SUV max.
Okay.
But
And
we just report the value, but not necessarily use that value to determine whether it's pathologic or not.
okay, you not use 2.5 like that. Just report the number, right?
Yeah, just report the number.
Okay. And I have like another question. So do you still use bone scan in the breast cancer? Or if the patient do the FDG PET CT, do you still do the bone scan?
Yes. In cases to evaluate the systemic disease, the bone scan is routinely used, and FDG PET scan can be used additionally.
So you do both in the same patient. You do
yes,
both.
we do both. Yes.
Okay. And last question. I read about the new tracer called FES. Do you use that in your hospital?
Maybe not yet. I know that tracer is developed in Asan Medical Center, but I think it is. I'm not quite sure if that is used in some study protocol currently, but it's not used in routine clinical work yet.
Okay. Because the benefit is like it's not that concrete.
Okay.
Okay. Thank you.
Have you used that tracer in your institute?
No, but I seen one hospital in my country. I live in Thailand. There is one hospital that used in
Okay.
research, and there are like sales price. They double the price of this tracer to promote the users, something like that. Yeah. It just started last year probably.
Okay. I see.
Okay. Thank you.
Thank you. So there's another question. So axillary lymph node is higher. Yeah, I've seen that cases a lot actually, but I don't have a clear answer for that. I'm not sure why that is the case in breast cancer. Like as in the previous case as well, the primary lesion is not quite big or intense. The FDG uptake is not intense, but the metastatic lesions has pretty high FDG uptake. So I don't have any clear answer for that. So, all right, let's move on to the second part of today's talk. So the talk is moving forward to the future, like so from the NCCN guideline and the potential value of FDG PET scan, and now it's a new tracer for HER2 imaging. Although it's been there for decades, but it's not used in the clinic yet. So as you all know, so HER2, so there are a lot of molecular imaging tracer, including FES, as you asked. But I think HER2 imaging has a very good promise for patient stratification and benefit for the patients. So as you all know, the HER2 is kind of a EGFR tyrosine kinase receptor, and the overexpression of HER2 leads to autophosphorylation of the tyrosine kinase, which is inside of the cell. And this tyrosine kinase is phosphorylated, then that initiates the intracellular signaling pathway, which leads to cellular proliferation and tumorigenesis. That is natural because this is a growth factor receptor. So growth factor should be activated under growth factor, but it's activated spontaneously, then it will make aggressive tumor. So HER2 positive status is associated with higher aggressiveness in breast cancer. And, and there are multiple HER2 targeted agents, which is approved and showing very good efficacy. So HER2 is a biomarker that is used for prediction of the treatment efficacy. And these are the 5 approved HER2 target therapy. 2 famous antibodies, trastuzumab and pertuzumab. And these 2 are the inhibitor of the tyrosine kinase domain, lapatinib and neratinib. And this is antibody drug conjugate, which means drug. A cytotoxic drug is conjugated to the antibody to give additional damage to the cancer cells. And this is approved TDM1. And you can see the site that binds to it. So pertuzumab and trastuzumab is bind to extracellular domain of the HER2. And these 2 tyrosine kinase inhibitor is bind to the intracellular domain. And also the same site with trastuzumab, TDM1 is bind to the same site with trastuzumab, but it has a cytotoxic drug load, so it is considered to have a higher efficacy and used for the HER2 positive breast cancer. And HER2 positivity is determined by immunohistochemistry or in situ hybridization in conventional assessment. So immunohistochemistry is most intuitive way to determine the biomarker expression. So you can see brown reactivity as HER2 expression. You can see there is no reactivity that is HER2 grade 0, and some like faintly or barely uptake in the breast cancer cell, which means it's grade 1, and weak to moderate goes to grade 2, and strong reactivity goes to grade 3. So 0 and 1 considered as HER2 negative, and 2 considered as equivocal or borderline, and 3 indicates positive for HER2 status. So this this is used in the clinic for the prognostic staging currently, and to decide whether using HER2 targeted imaging or not, or you can use in situ hybridization, which is looking at the cell nuclei to directly see the over expression of the HER2 genes. So using the CEP17 as control can obtain the ratio between the two. And if the ratio is higher than 2.0, it is considered as a positive HER2. You can see the right figure. Red dot indicates the HER2 gene, and CEP17 indicates the the control. So you can see the ratio of the number of dots is higher than 2.0 here. So it's positive. And if that ratio is less than 2.0, then consider as 2.0 negative HER2. And that is used in the clinic for the patient's stratification. However, those biopsy-based assessment of HER2 is very limited, actually, because biopsy can be done in one site of tumor or metastasis, and even the one site is very small site of the tumor compared to the whole tumor. So when you consider the heterogeneity of tumor nature, so there are a lot of intratumoral heterogeneity, and also there are a lot of intertumoral heterogeneity, which means it's if the HER2 is positive in one site in the tumor, then it could be negative in other side of that particular tumor, or it could be negative in the primary tumor, but it could be positive in the metastatic tumor. So those biopsy-based marker evaluation is very limited, but in vivo imaging, in comparison, is useful for evaluation of the prognostic marker, because in vivo imaging, especially positron emission tomography, we image the whole body, so you can check the expression of the primary and multiple metastatic lesions at one time. And also the imaging, in vivo imaging method is very useful for multiple time point evaluation, because biopsy is invasive procedure. So we cannot perform that multiple time points. So typically we do that during the staging, and after that it is hard to perform another biopsy during the treatment course. But in vivo imaging is non-invasive, so we can evaluate the marker expression during the treatment course and after the treatment, so that we can precisely know that if the marker is still there or not. because those markers can be changed during the chemotherapy or hormonal therapy period. So HER2 status can be evaluated with this in vivo imaging tracers. There are a lot of tracers were reported, mainly antibody-based tracers, because there are very good antibodies used in the clinic, including trastuzumab and pertuzumab. So zirconium-89 labeled trastuzumab and copper-64 labeled one, or copper-64 labeled pertuzumab, and some antibody fragments like FAB2 is used for the HER2 imaging. And also there are another type of tracer, including Affibody and aptamer. Affibody is a type of engineered scaffold proteins that has a specific binding affinity to a target. So this Affibody was developed to target HER2, and gallium-68 was labeled, and or other type of Affibody was reported, and F18 was labeled to it to see the HER2 status in vivo with in vivo imaging. And also aptamer can be is reported for HER2 imaging agent. So aptamer is not a protein, but it is oligonucleotide or peptide that has a high binding affinity to a target. So Affibody and aptamer is smaller than antibody, so it has a faster clearance, so that we can obtain the image in the same day after the injection of the tracer. However, these antibodies has a very long circulation half-life, and the uptake of the tumor is increased along during those time period. So we have to obtain the image at least 1 or 2 days after the injection. So that is one limitation about the antibody-based tracer, but still it has very nice affinity to HER2, which is confirmed for a long time. So the image quality looks better than the newly developed Affibody or aptamer in my point of view. So a few years ago, I have been involved in developing the copper-64 labeled pertuzumab, and antibody labeling is actually using a typical way of labeling the bifunctional chelator to the amine group of antibody. So amine group can be conjugated with SCN nota, and SCN nota can be labeled with copper-64, which can be chelated in the nota. And then in that study, we used actually ovarian cancer cell lines, not breast. And those cancer cell lines were these three, and it has strong HER2 reactivity expression in SKOV3 and moderate expression in other two cell lines. And with the cell lines, we made the subcutaneous tumor model like this. And as we expected, there was intense uptake after injection of copper-64 pertuzumab in the tumor area with a high HER2 expression, and the moderate uptake in the other two cancer models. And resected tumor shows a high expression of HER2 in SKOV3, but moderate expression in the other two cancer cell lines. Right. And then So this is ovarian cancer model, so it's not really a good fit for today's talk, but we made the orthotopic ovarian cancer model, which is implanted into the ovary. Ovarian cancer cells are implanted to ovary and find tumor formation using ultrasonograph, and then do the PET imaging. And we obtained a very nice PET-CT image and found that there is a primary tumor and multiple peritoneal metastasis with this tracer. So the tiny metastasis was confirmed after the excision of the two tumors, and the PET tracer uptake was very good. So this kind of studies have done by a lot of research groups, and now the trastuzumab or pertuzumab based antibody immunopet tracers are used in the clinic for the research purpose, for patients and for the research purpose. So in this study, they performed HER2 imaging using copper trastuzumab PET. And as you can see here, the breast cancer size are actually similar, but the tracer uptake is quite different, as you can see. And the tracer uptake was well correlated with the gold standard IHC scores. So with that, this immunopet imaging can be used for HER2 expression level. Then what is better for this? What is better for this imaging method to evaluate HER2? So there are some papers out there to show the efficacy or value of the PET imaging over conventional IHC method. So in this case, in this study, 56 patients with HER2 positive, according to the biopsy-based method, were enrolled. Since they are HER2 positive, according to the biopsy, the TDM1, which is antibody drug conjugate of trastuzumab, which is HER2-targeted therapy, was performed. But before that, HER2 PET-CT imaging was done. So HER2 PET imaging pattern was divided into 4 categories, and A and B considered to be positive, and C and D considered to be negative. So the definition is trastuzumab uptake positivity is considered as it's higher than blood pool activity, and pattern A indicates most of the tumors, all of the tumors are HER2 positive. And pattern B is more than 50% of the tumors, metastatic lesions, are HER2 positive. So A and B considered as HER2 PET positive. And C and D is, C indicates like very small proportion of metastasis has a HER2 positive, and D indicates there is no positive PET uptake in the HER2 PET. So note that all of these patients were initially HER2 positive according to biopsy, but according to the HER2 PET, there are the patients can be divided into like this. So C and D is HER2 negative according to HER2 PET, although they were HER2 positive according to IHC. And then they looked at the survival after HER2 targeted therapy. interestingly, according to the HER2 PET, if HER2 PET was negative, then HER2 targeted therapy was not very good. So the prognosis was bad. But if HER2 PET was positive, then HER2 targeted therapy was very good for the patients. So even though IHC result was positive for HER2, many of them will not gain benefit from HER2 targeted therapy because of the limitation of the biopsy-based HER2 evaluation. And then this study is thinking reverse. So previous study was enrolled the patients who were initially HER2 positive, but in this study, they enrolled HER2 negative according to the gold standard. Although they included only 9 patients, they found that, so these are the definition of HER2 expression, as which I explained already. And the 9 patient had a 0 or grade 1, which means HER2 negative. But after performing HER2 PET, they found there are multiple HER2 positive lesions, and then those lesions were confirmed to be HER2 positive according to gold standard method. And this is one case. So A is from primary tumor. It shows no HER2 reactivity. So this patient was classified as HER2 negative. But when they do the HER2 PET, they found that there was enlarged supraclavicular node metastasis with increased uptake in HER2. And they biopsied this, and they found that it was HER2 positive lesion. And then they performed HER2 targeted therapy, and the lesion was disappeared. And this is similar case with more dramatic change. So similarly, primary tumor was HER2 negative, but in HER2 PET there was increased uptake in the bone area, which was later confirmed by biopsy that it was the HER2 positive lesion. And then the patient underwent the HER2 targeted therapy. And before HER2 targeted therapy, FDG PET scan finding was like this. But after HER2 targeted therapy, FDG PET scan showed greatly improved status of the patient. So without the HER2 PET imaging, this patient will not receive the HER2 targeted therapy because the patient was HER2 negative according to the biopsy result. So this is a benefit of the HER2 PET imaging. And this one is more recent paper showing the clinical benefit of the HER2 PET. And in this case, it's kind of mixed population. So first one was initially HER2 positive, and second study was initially HER2 negative. And this study included the patients who are difficult to classify according to HER2 expression because 8 of these patients had 2 primary cancers, and those primary cancer, one was HER2 positive, and the other was HER2 negative, and the patients have multiple metastases, and they don't know if those metastases are HER2 positive or negative, and biopsy cannot be done for those metastatic lesions because it is too invasive. And 7 patients had metastasis, but it is inaccessible for biopsy. And 4 patients had a previous metastasis, both HER2 positive and negative. And it is hard to hard to perform the biopsy again, and one has equivocal HER2 status. So these 20 patients were enrolled, and HER2 PET was performed. And based on HER2 PET result, it was not clearly divided into positive or negative PET scan, and only one was equivocal. There is no clear description about the positivity and negativity in the manuscript, but I think the majority of the lesion is positive for PET, HER2 PET, then it is positive for HER2 PET, and majority is negative, then it will be negative, and somewhat in some HER2 positivity is found in very limited number of metastatic lesions, then it would be an equivocal finding. And then the 19 patients were not equivocal according to the PET imaging. And then they asked to referring physicians these two questionnaires. One is diagnostic understanding after PET imaging, and second is choice of therapy. So you can see for the diagnostic understanding, most of the questionnaire response was score of 4 or 5, which means PET provides information which substantially improved my understanding of this patient's disease. And 5 means the referring physician's understanding depended upon only by HER2 PET. So which is very nice. And the choice of therapy, most of the answer was within questionnaire score 3 or 5. 3 means PET did not alter my choice of therapy, but did increase my confidence in the choice. And 5 means the PET was very important compared to other factors in leading to a beneficial change in the therapy. So PET can give the referring physician of enhance the confidence of the treatment choice, or change the treatment modality according to the PET scan. So this is a summary of the treatment decision before and after the HER2 PET. As you can see here, the x-axis is the treatment plan before HER2 PET for these patients. They initially planned for anti-HER2 for 7 patients, but after PET scan, 2 patients considered to be negative, so they didn't receive the anti-HER2 treatment, so it's changed. And then initially they planned to not give anti-HER2 in 6 patients, but among 6 patients, 2 were able to receive HER2 targeted therapy according to the finding of HER2 PET. And there are 4 patients considering no systemic treatment, but among 4, 1 received anti-HER2 therapy according to the HER2 PET imaging. And there were 3 patients who were unsure about the treatment choice, but after the HER2 PET, they were assigned to HER2 positive or HER2 negative with strong confidence. So that was kind of clear benefit for the patient management. And this is, I think, actually better than FDG PET scan, because FDG PET scan can be used for treatment, can be used for more accurate patient stratification, and then and then change of the treatment modality, but most of the cases it's upstaging. But so because FDG PET cannot predict the response of specific treatment agents, but the HER2 PET can be used as a predictive biomarker, which means it can predict the specific treatment modality so that can give a more appropriate treatment method to the right patients, which is in line with the precision medicine. So that was all for the second part of today's talk. And these are the take-home message for whole story in today's lecture. So firstly, I explained that there are two different staging system, anatomic prognostic in 8th edition in breast cancer. And prognostic staging includes tumor grade, hormone receptor, and HER2 expression, and multi-gene panel testing. And FDG PETICT recommended for systemic evaluation in advanced or metastatic or recurrent breast cancers. And these are the statement with strong evidence. And then below is under development. So one FDG PET parameter can have a prognostic value. And the last part of my talk included the PET imaging for more better stratification of the patient to give the precise medication with the finding of the imaging, which is far better than biopsy-based evaluation. So that was it for today. Do you have any questions for today's talk? Okay. You don't have any questions? It's a little bit early than we scheduled, but I think it's good for all of us. So thank you for your listening to the lecture today, and have a good day. Thank you.